when you're sitting in a lecture hall in vet school or maybe you're cramming for boards late at night. It's incredibly easy to get completely lost in the
Oh,
lists.
absolutely. You're just memorizing lists of clinical signs,
Hmm.
lists of differential diagnoses.
Right, lists of drug dosages, exactly. But out in the real world, like in the actual exam room, a patient doesn't walk in as a bulleted list.
No, they don't. They walk in as a really complex puzzle. And your ultimate job is to translate those flat textbook notes into, well, immediate practical clinical intuition.
Because, I mean, a dog doesn't come in with a label that says, I have a prostate issue.
Right. They come in because their owner noticed something vague or perhaps absolutely nothing at all.
Exactly. So today, our mission for this deep dive is to really build that intuition for a very specific, incredibly common clinical puzzle. We are diving into canine prostatomegaly.
It's such an important topic. We're going to decode the diagnostics, explore the underlying cellular causes, and outline the exact clinical pathways you need to know.
Yeah, that way, the next time a middle-aged or, an older male dog walks into your clinic, you aren't just reciting a list of diseases from memory. You're actually fully prepared to act.
It is a critical topic to master because an enlarged prostate gland, it's not just one uniform disease process. It's really a physical manifestation of several very different, potentially life-threatening conditions.
Right, because when we say prostatomegaly, we're literally just saying abnormally large prostate gland. It's just an observation.
Exactly. The real work is figuring out the mechanism behind that observation.
Okay, so let's unpack this. We feel an enlarged prostate on rectal palpation, or maybe we catch it as a surprise on an abdominal x-ray. What is actually happening on a cellular level to make that gland swell up?
Well, it definitely isn't just one single pathway. The enlargement can happen for several distinct pathological reasons.
Like what, specifically?
It could be epithelial cell, hyperplasia, or hypertrophy, meaning the functional cells themselves are multiplying or physically growing larger,
Yeah.
usually due to hormonal stimulation.
Yep.
Or it could be neoplasia, which is a malignant tumor originating either in the prostatic epithelium or, the surrounding stroma.
Okay, so hormones or tumors. What else?
It could also be fluid dynamics, like cystic changes occurring deep within the prostatic parenchyma. Or it could be an intense, really sudden infiltration of inflammatory cells due to a severe bacterial infection.
So the puzzle isn't just the prostate got bigger.
Right.
It's really a question of what is actually making it bigger. Like, are we dealing with trapped fluid?
Right, or an army of inflammatory white blood cells.
Or rogue tumor cells, or just normal tissue that received a biochemical signal to grow totally out of control.
Exactly. And we also have to factor in that a normal prostate isn't some static universal baseline.
Oh, right, because it changes.
Yeah, its baseline size naturally varies depending on the dog's age, their body size, their breed, and crucially, their castration status.
I mean, a prostate in an intact Great Dane is going to feel vastly different from one in a neutered Chihuahua.
Completely different universe, which means your physical examination has to be highly nuanced.
Because when that gland is enlarged, the presentation varies wildly, doesn't it?
It really does. It can be perfectly symmetrical or it can be completely asymmetrical, feeling all lumpy and distorted.
And sometimes it's exquisitely painful when you touch it, or the dog might not even flinch.
That variability directly dictates the clinical signs we see. Because in some cases, there are absolutely none.
None at all.
None. The dog is completely asymptomatic, and you only discover the prostatomegaly as a surprise, an incidental finding during a routine physical exam for vaccines.
Wow. But when they do present with clinical signs, the owner's complaints can be incredibly misleading, right?
All highly misleading. They might describe the dog straining to defecate, producing these flat, ribbon-like stools.
Or they might describe dysuria, like straining to urinate and urethral outflow obstruction.
Yeah, and to really visualize why a reproductive gland causes gastrointestinal and urinary signs, we need a good mental model.
Right. And I always fall back on this analogy for that. I tell vet students, think of the prostate like a donut.
A donut. Okay, I can see where this is going based on the pelvic anatomy.
Yeah, so picture this donut sitting in the pelvis. It's a reproductive and urinary gland, and the urethra runs right through the hole in the very middle of that donut.
Right down the center.
But the whole structure sits in this severely crowded neighborhood, basically right beneath the colon. So when that donut starts expanding due to hyperplasia or inflammation, it expands outward, but it also swells inward.
Ah, yes. That dual expansion dictates exactly the pathology the owner observes at home.
Exactly. So if the donut swells outward, its outer edge presses directly against the adjacent pipe, which is the colon.
And that outward compression physically squishes the colonic wall.
Yeah, suddenly it makes perfect anatomical sense why a purely reproductive gland issue causes the dog to strain in the yard.
Or why the owner reports those flat, ribbon-like stools. The feces are literally being squeezed past this giant swollen donut that's taking up all the free space in the pelvic canal.
It's such a clear image. And conversely, if the tissue swells inward, closing the hole of the donut, it physically pinches the urethra.
Which is that internal compression that leads directly to the dysuria, the painful, really difficult urination.
Right. The dog might just drip urine or take forever to empty their bladder. And in severe cases, the swelling completely seals off the pipe.
Yeah, resulting in total urethral outflow obstruction. It just creates a perfect anatomical bottleneck.
So the takeaway for us, standing in the clinic is massive. When an owner comes in complaining about gastrointestinal issues, like maybe they think their older male dog ate something bad and is just constipated.
We have to remember the anatomical neighborhood.
Exactly. We cannot tunnel vision on the GI tract. That constipation might actually be a swelling donut.
It's a really great analogy, but recognizing the physical presentation is only the first step. Once we identify the enlarged gland, we have to determine the why.
The root cause.
Right, and this is where the diagnostic pathway can completely flip upside down based on just a single piece of patient history.
Let's run through those primary culprits then. We're typically dealing with benign prostatic hyperplasia, or BPH. Then there's squamous metaplasia.
And then the aggressive malignancies. Things like adenocarcinoma, transitional cell carcinoma or TCC sarcoma, and metastatic neoplasia.
And finally, we have the infectious or inflammatory disasters, acute bacterial prostatitis, chronic bacterial prostatitis, prostatic abscesses, and cysts.
It's a long list.
Yeah.
Narrowing down that extensive differential list requires looking closely at risk factors. And the absolute most significant factor in veterinary medicine regarding the prostate is castration.
Okay, here's where it gets really interesting. Because from day one of vet school, you are taught that neutering is the ultimate preventative measure, right? It's framed as the gold standard for preventing prostate issues. Castration definitively lowers the risk of benign prostatic hyperplasia and bacterial prostatitis.
And that makes complete biological sense. BPH is driven by hormones, specifically the conversion of testosterone to dihydrotestosterone, or DHT, within the prostate.
So you remove the testicles, you remove the testosterone, and you remove the fuel for the hyperplasia. The gland shrinks.
Right. But the data reveals a terrifying twist.
Yeah, this is the part that blows my mind. The risk of adenocarcinoma actually increases threefold in castrated dogs compared to intact dogs. Threefold.
It's a striking statistic.
That feels like it goes against everything we are taught about preventative medicine. Wait, as vet students, you are taught that neutering is the ultimate preventative measure. How does knowing a dog is castrated change our entire clinical suspicion when we feel an enlarged prostate?
If we connect this to the bigger picture, it forces a massive diagnostic pivot. Because BPH and bacterial prostatitis are so reliant on an intact hormonal environment, they are exceptionally rare in castrated dogs. Therefore, if a neutered older male dog presents with prostatomegaly, you cannot default to the most common benign assumption.
Because the biological vacuum left by the lack of hormones means something much more sinister is likely at play. They simply don't have the hormones to drive a benign enlargement.
Precisely. You must immediately bump primary or metastatic neoplasia to the absolute top of your differential list.
Wow.
That threefold increase in adenocarcinoma risk means an enlarged prostate in a neutered dog is a blaring red flag. It is a critical concern until proven otherwise.
That is a major aha moment for clinical practice.
Yeah.
Intact dog with a big prostate. The odds favor BPH or an infection.
Right.
Neutered dog with a big prostate. Sound the alarm for neoplasia.
It is arguably one of the most reliable diagnostic rules of thumb we have in small animal medicine.
Okay, so with those varying risks in mind, how do we confidently play detective? We have the big five major categories: BPH, neoplasia, acute bacterial, chronic bacterial, and abscesses or cysts.
Right.
How do we pull these apart using, our hands, our labs, and our imaging?
The differentiation begins the very moment you perform your rectal exam. Your hands are your first diagnostic tool.
Let's break down that palpation. With BPH, the gland is going to feel symmetrically enlarged and generally non-painful, right? The donut is just evenly oversized.
Exactly. The dog might find the exam uncomfortable just because of the location, but the gland itself isn't radiating pain.
But neoplasia feels entirely different.
A neoplastic prostate is typically exquisitely painful and non-symmetric. It might feel firm, rocky, or irregularly nodular.
Ugh, rocky is never a word you want to feel.
No, never. And beyond the local exam, these dogs are often systemically ill. You frequently see significant weight loss, lethargy, and impaired appetite, and occasionally rear limb weakness.
And that weakness, is that from the tumor itself?
It can occur either due to metastasis to the lumbar spine or the tumor locally impinging on the nerves traversing the pelvic canal.
That's awful. Okay, what about acute bacterial prostatitis? That's also going to be painful, right?
Very painful, but it can present as symmetric or non-symmetric. Because it's an acute, severe infection, the systemic alarms are ringing loudly.
So they'd have a high fever.
Often a high fever, they refuse to eat.
Yeah.
They might have that same rear limb weakness due to pain, and they will likely have a tense, visibly painful abdomen.
Got it. And chronic bacterial prostatitis, is that just a milder version?
It's much more insidious.
Yeah.
The clinical signs might mimic the acute form mildly, or they might just present as a dog with a stubborn, recurrent lower urinary tract infection.
Like it clears up on antibiotics and comes right back.
Exactly. The severe systemic signs, the high fever, the acute agony, are much less common. The dog's body has basically adapted to a smoldering, persistent infection.
Okay, and finally, we have abscesses and cysts.
Cysts present as palpable caudal abdominal masses. They can cause that straining to urinate or defecate if they grow large enough, or they might be completely silent.
And abscesses.
Abscesses, on the other hand, are literal pockets of infection. They generally mimic the clinical signs of acute or chronic prostatitis.
Okay, so once your hands have given you a physical roadmap, you need a chemical snapshot. The CBC, biochemistry, and urinalysis are vital for corroborating those physical findings.
They absolutely are, though the blood work for BPH is remarkably boring.
Boring is good, so normal CBC.
Usually normal. The urinalysis might be completely unremarkable, or you might see some mild hematuria blood in the urine just from the hyperplastic tissue being friable.
And we also know that serum prostatic esterase concentration might be elevated in dogs with BPH, right? Giving us a specific biomarker?
Yes, that can be a helpful clue. But when you shift to the infectious or neoplastic categories, the lab work really wakes up.
I'd imagine.
If there is a pocket of infection or severe inflammation sitting in the pelvis, the systemic alarms go off. You'll almost certainly see a massive leukocytosis, a high white blood cell count on the CBC.
There is also a very specific, almost bizarre clue for abscesses hidden in the biochemistry panel, isn't there?
There is. You will often see elevated bilirubin and elevated alkaline phosphatase, or ALP, in patients with a prostatic abscess.
Why is that? That seems so random.
It's a strange systemic response, likely due to the intense localized inflammation causing secondary systemic effects on the liver. But it is an incredibly useful diagnostic breadcrumb.
Wow. And the urinalysis is where things get really messy, right? If that donut is squeezing the urethra or actively inflamed, we're bound to see collateral damage in the urine.
You absolutely will. For bacterial prostatitis, the urinalysis will reveal pyuria, which is a massive influx of white blood cells into the urine. You'll also see hematuria, proteinuria, and bacteriuria.
So it essentially just looks like a classic severe urinary tract infection.
Exactly. For prostatic neoplasia, you'll see a very similar inflammatory sediment, but occasionally you get lucky and actually catch malignant neoplastic cells shedding directly into the urinary stream.
But blood and urine only tell us that an infection or an inflammation is happening somewhere. To confidently stick a needle in that dog or decide not to, we have to map the actual physical geography of the prostate.
Right, we need ultrasound. Radiographs are great for confirming the prostate is enlarged and pushing the colon up, but ultrasound acts as our diagnostic echolocation.
I love that echolocation.
Ultrasound is arguably the most powerful tool in this entire workup. The way the high-frequency sound waves bounce back off the tissue tells you exactly what architecture or fluid is trapped inside that enlarged gland.
Okay, let's map out this echolocation. If it is an abscess or a cyst, the ultrasound will show hypoechoic or anechoic lesions. Visually, these are dark, black spots on the screen, right?
Correct. Because fluid doesn't bounce sound waves back to the probe, the waves travel straight through, often creating what we call distal enhancement behind the fluid pocket.
That is the classic appearance of fluid. Now, what if we were looking at acute bacterial prostatitis or uncomplicated BPH?
The gland generally maintains a uniform echogenicity. It looks like a smooth, even gray sponge on the screen.
Though with BPH, I know you might occasionally spot tiny fluid-filled cysts scattered uniformly throughout the hyperplastic tissue.
Yes, that can definitely happen.
What about chronic bacterial prostatitis? I imagine the constant inflammation changes the tissue density over time.
It does. Chronic inflammation leads to fibrosis and scarring. Because scar tissue is denser, it reflects more sound wave.
Oh, so it looks brighter.
Exactly. On the ultrasound, you will see focal or diffuse hyperechogenicity. The tissue looks brighter and much more disorganized compared to a healthy prostate.
Which leaves neoplasia. And this one sounds terrifying on the screen. It is described as having focal to multifocal areas of coalescing echogenicity, combined with something called acoustic shadowing.
Yes.
How exactly does a tumor cause acoustic shadowing?
Acoustic shadowing is a really fascinating physical phenomenon. It occurs when tissue becomes so incredibly dense, often because the malignant tumor has begun to calcify and mineralize, that the sound waves cannot penetrate it whatsoever.
It just blocks them entirely.
Completely. The mineralized tissue acts like a brick wall, bouncing 100% of the sound waves back to the probe. Because no sound waves pass through, the area immediately behind the tumor appears as a deep, dark, black void, a shadow. When you see that chaotic, mixed echogenicity combined with dark mineral shadowing in a dog's prostate, your concern for carcinoma should be extraordinarily high.
Okay, let's unpack this next part. So we see something concerning on the ultrasound, or we need a definitive answer to formulate a treatment plan. The next logical step would be a biopsy or a fluid culture.
Right. We can get prostatic fluid via ejaculation or prostatic massage, looking for more than 100,000 colony-forming units of bacteria per milliliter to confirm an infection.
Or we use the ultrasound to guide a needle biopsy directly into the tissue. But wait, what happens if we accidentally poke an abscess? I mean, sticking a needle blindly into a potential abscess sounds like a fantastic way to cause a massive abdominal infection.
That is a phenomenal point, and it highlights a critical danger. You must exercise extreme paranoia to avoid the iatrogenic rupture of a prostatic abscess.
How bad is it if it ruptured?
If you accidentally burst that pressurized pocket of infection with a biopsy needle, or, frankly, even by pressing too aggressively during your rectal palpation, you will spill that highly contaminated fluid directly into the abdominal cavity.
Oh no, which transforms a localized pelvic issue into a complete systemic nightmare.
A total nightmare. An iatrogenic abscess rupture will cause sudden fever, acute cardiovascular shock, severe caudal abdominal pain, and it quickly spirals into a life-threatening septic peritonitis.
That is terrifying.
It is. You only perform biopsies when you have clear ultrasound visualization, and if you suspect an abscess, you proceed with absolute surgical caution.
Okay, so once we have navigated the diagnostics, avoided bursting any abscesses, and secured our answer, how do we actually fix this? The treatment has to be as specific as the diagnosis.
The pathways diverge sharply here. Surgery is frequently the definitive, permanent fix.
Right. Surgical castration is the undisputed treatment of choice for symptomatic dogs with BPH. You remove the testicles, you eliminate the testosterone conversion to DHT, and the hyperplastic tissue simply atrophies.
It's very effective. Castration is also used to treat bacterial prostatitis, but timing is everything here.
Because of the infection.
Exactly. You only perform the surgery after the acute systemic infection is resolved with antibiotics. You absolutely do not want to put a dog actively fighting a severe systemic infection under general anesthesia unless it is an unavoidable emergency.
Makes total sense. And if the ultrasound revealed a massive prostatic abscess or gigantic space-occupying cysts, simply removing the hormones via castration isn't going to drain the fluid, is it?
No, it won't. Those conditions require intensive surgical intervention, like omentalization or surgical drainage, to physically resolve that pocket of infection.
But what happens when surgery just isn't an option? Say the dog is a highly valuable breeding stud, or the owner adamantly refuses castration, or maybe the patient has severe cardiac disease and cannot survive anesthesia.
Then we have to pivot to medical management.
And rather than just memorizing a list of drug dosages, we need to understand the mechanism of how these drugs manipulate the prostate.
The pharmacology is actually incredibly elegant. If castration is unacceptable, we try to mimic its effects medically to produce a temporary reduction in prostate size.
Like with finasteride, right, which is an enzyme inhibitor. It specifically blocks 5-alpha reductase, the enzyme responsible for converting testosterone into DHT.
Exactly. By blocking that conversion, the prostate shrinks, but the dog often retains breeding capability and testosterone levels.
The other route involves synthetic progestins, like magistral acetate or medroxyprogesterone. These drugs act by suppressing the pituitary gonadal axis, driving down testosterone production.
But this creates a massive clinical trap.
Yeah, you cannot just prescribe these synthetic hormones indefinitely to avoid surgery.
It is the ultimate example of the cure becoming worse than the disease. Long-term administration of drugs like magistral acetate heavily interferes with insulin receptors.
Oh, wow.
If you leave a dog on these medications, you will almost certainly induce diabetes mellitus.
So you successfully shrink the prostate, but you hand the owner a lifelong, complex endocrine disorder requiring daily insulin injections.
Precisely. This is why surgical castration remains the gold standard for BPH. It is a prominent, non-diabetogenic solution.
The pharmacology of treating bacterial prostatitis is equally tricky, isn't it? A vet student might assume the protocol is simple: culture the fluid, read the lab report, pick the antibiotic with an S for susceptible next to it, and just write the script.
What's fascinating here is, if only it were that simple. The prostate gland does not play by normal tissue rules. It is protected by the blood-prostate barrier.
Ah, right.
You can't just choose any antibiotic that kills the bacteria in a petri dish. The drug must actually possess the specific pharmacokinetic properties required to physically cross that cellular barrier and diffuse into the prostatic fluid in therapeutic concentrations.
And most standard water-soluble antibiotics bounce right off. The barrier is highly lipophilic, meaning the drug has to be lipid-soluble to penetrate the tissue.
Furthermore, normal prostatic fluid is slightly acidic. This creates a phenomenon called ion trapping.
Ion trapping. Right, so we need drugs that are basic and lipophilic, allowing them to cross the barrier, become ionized in the acidic prostatic fluid, and become trapped right where the infection is actually raging.
That pharmacokinetic reality cuts your antibiotic options down drastically. Your susceptibility panel is only half the battle. You have to match the susceptible drug with one capable of penetrating the barrier.
Which ones actually work?
Fluoroquinolones, trimethoprim sulfa, and chloramphenicol are excellent choices because their chemical structures allow them to achieve therapeutic concentrations deep within the prostatic tissue.
That is the kind of clinical pearl that really saves lives. Don't prescribe an antibiotic that can't reach the battlefield.
Exactly.
Now, what about the most devastating diagnosis, prostatic carcinoma? If we find a mineralized tumor in a castrated dog, do we have an effective pharmacological weapon?
Tragically, no. Standard chemotherapy has simply not proven beneficial for prostatic carcinoma in dogs.
That's heartbreaking.
It really is.
Yeah.
It's a highly aggressive, rapidly metastasizing disease with a profoundly poor prognosis. This reality reinforces why catching it early, specifically by paying attention to that enlarged prostate in a neuter dog, is so utterly critical, even when our oncological options remain frustratingly limited.
Which brings us to the final phase of the clinical puzzle: follow-up. You don't just hand the owner a bottle of fluoroquinolones or perform a castration and say, we'll see you next year.
No, patient monitoring proves whether your clinical intuition was right. You must use follow-up abdominal x-rays or prostatic ultrasounds to objectively measure the efficacy of your treatment.
Like, is the donut actually shrinking, or did we miss a concurrent tumor?
Exactly. And for bacterial prostatitis, clinical improvement isn't enough. The clinical signs might vanish, but the bacteria could be hiding.
Right.
You must follow up with urine and prostatic fluid cultures to definitively prove you have eradicated the infection, rather than just temporarily suppressing it.
We have covered an immense amount of clinical ground today. We started by looking at the physical reality of prostatomegaly, the cellular mechanisms, the asymmetrical versus symmetrical exam findings, and that donut anatomy that explains why a swollen reproductive gland causes ribbon-like stools and urinary bottlenecks.
We explored the castration paradox, learning the biological logic of why neutering prevents BPH, but why it demands that we instantly suspect adenocarcinoma if a castrated dog presents with a swollen gland.
We formulated a diagnostic plan, relying on the leukocytosis and elevated bilirubin of an abscess and mapping out the internal architecture with the echolocation of an ultrasound.
We also discussed the sheer panic of an iatrogenic abscess rupture, the diabetes risk of synthetic progestins, and the complex ion-trapping pharmacology required to push antibiotics across the blood-prostate barrier.
And underlying all of this clinical decision-making is the ultimate consequence. If prostatomegaly is misdiagnosed or unmanaged, the swelling donut will eventually cause severe, life-threatening urethral or rectal obstruction.
It transforms a manageable disease into an immediate surgical emergency.
Before we close out today's deep dive, I want to leave you with a final thought. Something outside the standard clinical algorithms to ponder as you continue developing your intuition.
Hmm.
If surgical castration brilliantly eliminates the risk of BPH, but simultaneously triples the risk of highly aggressive adenocarcinoma, how might veterinary medicine eventually need to rethink the hormonal management of the canine prostate?
It's a great question.
Could there be a biological middle ground in preventative care, perhaps a hormone-sparing procedure or a highly targeted gene therapy that protects against the benign swelling without opening the door to the malignant extreme? Keep questioning the baseline assumptions, keep connecting the clinical dots, and we will catch you on the next deep dive.